This is actually, I think, pretty easy, like identifying these muscles and thinking about their action. And it's kind of fun, hopefully. The way to think about it is like they've done here. We got some muscles that are more superficial, and then we got some muscles that are deep. To see the ones that are deep, you got to remove glute max, and even removing med helps a little bit. Here you can see how you can follow the hamstrings up and see how they're attaching to the ischial tuberosity, right? But if I remove glute max, now I can see these short lateral rotators, and if I remove glute medius, I can see glute minimus. Okay? You can see too here have glute max in addition to attaching to the femur is attaching to the IT band. Okay. So this is another one. Okay, I put this in here. Please don't waste time like memorizing this, but just to give you the sense, like a lot of muscles coursing over the hip joint, so supporting it, and we can group these muscles into functional units, and that's going to be a key for our understanding of upper limb and lower limb functions. You know what I mean? So we got a flexor compartment and an extensor compartment and an abductor compartment. You get the idea, okay? So again, obviously you got some muscles that cross the hip joint in front. They're gonna flex at the hip joint. You got them crossing in the back. They're gonna extend. You got it crossing on the side. They're gonna abduct. Whereas medial thigh muscles are gonna bring you back to the midline. They're gonna adduct. It's self-explanatory. Okay. So again here too. So if you got one in the front, it's probably gonna be a flexor. And if you got one in the back, it's probably gonna be an extensor. You know what I mean? Okay. So let's think about some flexors crossing the hip joint. Iliopsoas, powerful flexor. Of course, because we want to be precise in our terminology, like just at the neck, you can have flexion, but you can also have lateral flexion. At the hip joint, you can have flexion thanks to iliopsoas, but you can have lateral flexion. Any of you in the yoga, do these moves a lot. Thanks to quadratus lumborum, which is a muscle running off iliac crest. Okay, so iliopsoas has really two parts. It's got a part running off the fossa of the ilium, so right here. And a part running off lumbar vertebra. Okay, that's the psoas part. And they merge, and then that merged combo muscle travels under the inguinal ligament that we just talked about, and it's going to attach to the lesser trochanter of the femur. So this is an important attachment site, and that's the powerful flexor at the hip. So mostly femoral nerve with a bit of contribution from some other lumbar plexus parts, but mostly femoral. Okay, psoas. And you can always go to these tables for more detail. I just put it in here knowing that you don't have time to read all your textbooks, right? So you can go here if you want. So that's probably the most important flexor, at the hip joint, iliopsoas. And that's one of those core muscles too that people think about. Although there's other more important core muscles that we'll talk about later. So what if we wanted to bring the thigh back to the midline? In other words, what if we wanted to adduct the lower limb? We're going to use the medial compartment. And by the way, I'm kind of going through this quickly because the thigh lecture and lab, which is next week, is going to do this, right? Okay. So just so you're aware, next Monday we're going to have a lecture on the thigh, okay? And then next Wednesday is a lab exam, and the following week, I don't know. It'll hopefully all work out, people. I don't know what I've done before, but somehow we'll get a thigh lecture lab in there. Yeah, probably 2 weeks from now. Okay, so that's why I'm not going to go over all these details. Okay, we're getting this later. Okay, getting all this later. But anyways, these muscles, and you can see they're running from the midline out here laterally towards the femur. So if they shorten, if they contract, they're going to bring the femur back towards the midline. They're going to get adducted. For us, right now, let's just think about these as adductors, and they're innervated by the obturator nerve. That's the nerve going through that obturator foramen that I showed you, right? Okay. Lateral rotators, this is a big part of today, okay? To see these guys, they're kind of cute, okay? 6 little cute guys hanging out under glute max. And so you gotta reflect glute max to see these guys. And we use this mnemonic because P, go, go, Q, because each of those letters is the first letter in the name of one of these muscles. So like P is piriformis, O is one of the obturator muscles, right? Q is quadratus femoris, you get the idea. Okay. So we'll think about these later. But they all laterally rotate the thigh at the hip. And to see them, you gotta reflect the glute max, okay? All right. Variable nerve innervation, so more on that later too, okay? Glute max can help a bit with lateral rotation. So here, although it's a powerful extensor, glute max, okay? So here, we've reflected glute max. In fact, we have a body where we removed all of glute max except this little strip. Sometimes people look at, man, this person just had the world's teeniest glute max. No, we got rid of it. We just left this teeny bit of glute max because what's cool about it on that body is you can see the inferior gluteal nerve right to it. That's why we left it. But to remove glute max, get a nice, beautiful view of short lateral rotators. And what I think helps to orient you, especially if it's your first time, is to find piriformis coming out of the greater sciatic foramen, heading to the greater trochanteric femur. There it is. And you know what though? Like you can confuse piriformis with some other short lateral rotators. So the second thing you look for is the largest nerve in the body, also coming out of the greater sciatic foramen, and typically traveling under piriformis. This is called the sciatic nerve. So we'll look for that. That's how I start. Before I try and find any other P, go, go, Q muscle, I find piriformis, the sciatic nerve coming out under it. Then I start looking for other stuff. Okay, so more on that later. Okay, cool. Moving on. Here's piriformis coming out of the greater sciatic foramen. I'm not remembering if I do this later, so I'm going to do it now and later maybe. So once again, let me do this with black. Piriformis. Next, we have triceps of the coxal bone. We got the triceps in the arm. We actually have the triceps in the calf, and then we have one other triceps in the body, which is right below piriformis. It's 3 muscles, and you can see them here. So it's called triceps coxa. This is not the best artistic representation of it. Let me draw it and then I can show you this like this. The first part is superior gemellus. The second part is obturator internus. This is a cool muscle that makes a 90-degree turn, like that. And the third muscle is inferior gemellus, or gemellus, or pronounced both ways. You put the 2 gemelli and the obturator internus together, you got a triceps coxa. Then there's an obturator externus right below it, deep to it, hard to see. And below that is a muscle that's easy to see. It kind of looks like a square-shaped muscle, so that's quadratus femoris. So we start at piriformis, and we end at quadratus femoris. So if you go back in your mind to that hole in the coxal bone called the obturator foramen, And if you recall, I said we're going to cover it with a membrane. If we then add a muscle on either side of that membrane, like we sandwich the membrane, that's how we make the obturator muscles, and that's why they're called obturator muscles. There are two muscles, one on each side of that obturator membrane. Okay. So one of them's on the outside, so it's obturator externus. Well, that's horrible. And then the other one's on the inside. That's obturator internus. Please don't draw like that in your exam. That's the world's worst attempt ever at drawing obturator externus and internus. I'll show you a picture later. So here's triceps. Check it out. Superior gemellus at the top. Inferior gemellus below. And then you see how there's a tendon between them? You can see that in a couple of our cadavers. And so obturator internus goes like this, and it's a different color. Here's the tendony part. And then look at this, it goes under the sacrotuberous ligament. And then it fans out here, so it goes like this. It makes a 90-degree angle. Okay, that's obturator internus. And it ends up, after it makes that 90-degree angle, it ends up forming the wall of this fat-filled space, which is the ischio-anal fossa, right, where the pudendal nerve is traveling. So obturator internus makes this cool thing. You can turn. Here it is, right down here. And it's forming the wall of the ischio-anal fossa. Okay. So that's the triceps of the coxal bone. Then we have an obturator externus, and this is tricky to see. We will show it to you on the cadaver, and if you can imagine, it's coming off the external aspect of that membrane that's covering the obturator foramen. So see, right? That's the obturator foramen I'm outlining, and this muscle is coming off of it there. Obturator externus. Okay. Obturator nerve innervation. And then here's more detail on these guys, these short lateral rotators, and their nerve innervation. And we'll model them in discussion lab. We'll see them on multiple cadavers. And we got in the back hip extensors. Of course, the major one is glute max, and your hamstrings. Of course, Maximus plays a big role when we're getting up out of chairs, when we're walking up hills, when we're running. Now I'm going to go off on a little evolutionary hominid tangent. In other primates, the other gluteal muscles also are basically extensors, and that is because of the shape of their hip bones. I started this lecture spending quite a bit of time on the pelvic girdle. So in humans, the glute medius and glute minimus are not extensors. They are abductors primarily, okay? And the reason they're abductors and they're not functioning as extensors like glute max is one, because of their attachment off the ilium, but because of how the ilium in humans has shifted. In other primates, the ilium is more oriented just posteriorly, but in humans it rotates laterally. So now glute med and glute min are more oriented this way, so they're going to function like abductors. So now, a couple comments on that. I think I was talking with some of you last week about this. I prefer the attachment term proximal and distal to origin and insertion, just because oftentimes a muscle can have two radically different functions depending on whether one of its attachment sites is planted on the ground or things like that. And then in that case, origin insertion kind of doesn't work. Another case is like anterior belly of the digastric, which is the muscle that runs from your mandible to your hyoid bone. So, so it turns out if the hyoid bone is stabilized in the neck, then when anterior belly of the digastric work, it's going to pull your jaw down. Cool. But if instead the hyoid bone is not stabilized, then anterior belly of the digastric is actually going to elevate the hyoid. Okay, so in that case, origin insertion makes no sense. Proximal and distal makes more sense. Here too, glute medius and glute minimus. Their function depends on whether the lower limb is planted on the ground or not. If it's not planted on the ground, glute medius and minimus are going to abduct the lower limb. If it's planted on the ground, instead it's going to stabilize your pelvis. So that when we walk, right, if you look at my pelvis when I walk, it looks pretty stable, pretty horizontal. If you geek out on nature videos, which I like to do, and you look at chimpanzees who choose to walk on two limbs, their pelvis drops from side to side. And it's dropping from side to side because their other gluteal muscles do not function like ours. Their pelvic girdle is differential. It is shaped differently from ours. Gorillas are the same, okay? Interestingly, if a human has damage to the nerve, to medius and minimus, when they walk, they'll start walking, I'm exaggerating a bit, but they'll start walking a bit like a chimpanzee or a gorilla. The pelvis will drop to the opposite side of the lesioned nerve. So if on the left side, my glute medius and minimus are weak because the superior gluteal nerve is damaged, my hip will drop to the right when I walk. And that's called a Trendelenburg gait. So these guys have kind of been repurposed during evolutionary history to function as abductors. And they play this really important role during bipedal locomotion of keeping our pelvis horizontal, okay? When we locomote on two limbs, if you damage the nerve to these two muscles, superior gluteal nerve, then the pelvis will drop to the opposite side when you walk. Okay? And so you can see here, glute med and minimus, why they function as abductors. Okay? Whereas glute max, most of its mass is more posterior, so it's more of an extensor, right? Okay. Here is my little evolutionary picture. If you look at a chimpanzee ilium, the surface that the gluteal muscles attaches to is basically just posterior facing. Okay? But in humans, it's been rotated a bit. Okay? Interestingly, this transitional hominoid, the Australopithecus, first discovered, I think, in fossils in Tanzania or something like that. We think is the first hominid with evidence of bipedalism. And one evidence is the shape of the pelvis of Australopithecus. Okay? So anyways, I guess I'm making the story longer than I should. The ilium has been repositioned in humans, modern humans, okay? To allow glute medius and minimus to function both as abductors and keep the pelvis flat. Here's the gluteal lines that medius and minimus are attaching to. So we can look for these on pelvic bones. Medius and minimus attaching to the greater trochanter. So yet again, another reason we care about the greater trochanter. Here's a discussion about Trendelenburg gait. So you damage superior gluteal nerve on the right side, pelvis will drop to the opposite side during locomotion. Let me draw for you a piriformis coming out of the greater sciatic foramen. It's attached near the greater trochanter. So when you're looking for the gluteal nerves and vessels, go into the gluteal muscles. Here's how you find them. The superior gluteal nerve and vessel are named because they come out superior to piriformis. And the inferior gluteal nerve and vessel are named because they come out inferior to them. So that's how you find them. Inferior is going to glute max. Superior is going to 3 guys. Glute medius, and glute minimus, and tensor fasciae latae. Right. So this tensor fasciae latae inserts into the IT band along with glute max, also innervated by superior gluteal nerve. If you're looking, you remember that rule I taught you guys last week? Generally speaking, more often than not, the muscle covers the nerves that innervate. So like, you know, if you're looking here, I don't see inferior gluteal nerve going to glute max. I have to reflect it. Likewise, if I'm looking here at glute medius, I don't see the nerve going to it. It's actually underneath. So if you want to see the inferior gluteal nerves, you gotta reflect glute medius. Oh, another little clinical correlate. Have any of you ever had I'm not trying to be personal, but but have any of you ever had intramuscular injections, or some of you have, like some of the COVID vaccines were delivered that way. If you had it delivered that way, it was probably delivered into your deltoid. But they sometimes will do it into the buttocks, into glute max, because it's pretty hard to miss glute max. But if you're doing that, this is what you don't do. You don't do an intramuscular injection into glute max down south. Why? Because the biggest nerve in the body is right under there. You don't want that needle going right into the sciatic nerve, because you'd have to be a horrible physician to like jam the needle in somewhere, but like it can happen. So you do it in this lateral superior quadrant, you do it up here, right? Intramuscular injection into glute max, just to avoid inadvertently damaging the sciatic nerve. Let's see where the sciatic nerve is. See, so glute max is here. You don't want to do an injection down here. You want to do it up north and a little bit lateral, so superior lateral injection. You see where it happens. Oh Lord. No, I think we're okay. I think 3:30, right?
Yeah.
You guys play some bets? Right. Okay. So, lumbosacral plexus, we're going to be exploring this a lot over the next few weeks. I'm introducing it now because this is the plexus that's innervating the muscles we've just been talking about. So in particular, this week, we're going to try and identify obturator nerve, or at least think about it, because it's going through the obturator foramen. It's not really that important for lab, but we can think about it. We can think about femoral nerve. This is really thigh people, but start thinking about it. But really relevant to lab, superior gluteal, inferior gluteal, and sciatic. Okay, sciatic technically is a combo nerve. We can worry about that later. So, eventually you're gonna have this down in your sleep. I should warn you. Maybe Raphael's already, but he has these exams where I think he has you draw a nerve out of a hat, and then you have to verbalize its complete trajectory to very minute detail. Okay, so maybe you draw, I don't know, superior gluteal nerve out of the hat, or sciatic nerve, or common fibular, whatever. So just giving you a heads up. He does the same exam for upper limb. Okay, so that's also where our courses interact and inform each other, and I try and also help you out, get a sense for the trajectory of these nerves. That's one thing you really want to get when you're in cadaver lab, think about that pathway, right? We're gonna first see sciatic nerve coming out of greater sciatic framing under piriformis. It's all stuff Raphael's gonna expect you to know. And it's going down, right, behind the hamstrings, right? Now it's in the popliteal fossa, then it divides. You gotta know where it typically divides. Then what happens to each branch that divides, right? So all of that. Where is it likely to get impinged? All these different impingement locations you're gonna have to, I call those danger zones, right? At Halloween. We can talk about that later. Okay, so here's the lumbar plexus, and we're doing all this later, so yeah, let's not worry about it right now. We're gonna do, when you do the thigh, we're gonna think about these guys. The thigh. Lectures next week, lab is 2 weeks from now, I believe. And when we do the abdominal wall, we'll think about these guys. Okay? So we'll come back to this. But maybe, because I talked about, right, the inguinal ligament running from ASIS to pubic tubercle, and how the femoral nerve travels under there. Might as well start thinking about femoral nerve roots L2 to L4, because we talked about obturator foramen and obturator nerve going through there. We also talked about, maybe you forgot, obturator artery goes through there and it gives off a little branch that goes to the head of the femur. Artery to the head of the femur. True or false? Artery to the head of the femur is the most important blood supply to the head of the femur. False. Good. My minions, you're doing great. Okay. But so we can think about obturator nerve too. That is the same root, so that's good. L2 to L4. But really, we'll identify femoral nerve and obturator nerve in 2 weeks in cadavers. The presenters this week, you don't have to show us obturator nerve and femoral nerve. Okay? You don't have to flip the body to the front. Okay? So likewise, this view here, we're going to get I think thigh people, just thinking, is anyone here doing thigh presentation? So, okay, I would like you to do this view. And there's a couple cadavers. I think this, I don't remember the names, but how there's a sheet in the lab with cadaver numbers with important things on each. I want you to kind of show us the nerves going to the thigh in 2 places, in the thigh and here. So for example, just lateral to psoas. Here's psoas. Is femoral nerve. I want you to show us there, and then after it's gone under the inguinal ligament, you're going to show us femoral nerve here, okay? Likewise, lateral femoral cutaneous nerve of the thigh. It's the nerve doing sensation to the front of the thigh and the lateral aspect. Easiest to see, coursing over iliacus. You can show us here, but we do have one cadaver where you can see it here. See what I'm saying? And likewise, obturator nerve on the medial aspect of psoas. I want you to show it. This actually isn't a good picture for it. I don't like this obturator, but you can show it in here, medial to psoas, and then you're going to definitely show it to us on the medial thighs. You know what I mean? So, you don't have to worry about this right now. We can worry about this in 2 weeks, but this is the posterior abdominal wall. Think about what we have to do to show this. We have to take the GI tract out, we have to take the guts out. If you do that, or push them to the side, that's the best place to see the lumbar plexus. So, just introduce it to you now. Don't really have to worry about it this week, people. That's why I'm going over this quickly. But in 2 weeks, when we do the thigh presenters are going to tie back. They're going to find a cadaver where they can show us the posterior abdominal wall, and they're going to look for the lumbar plexus nerves. Cool? Okay. And then you can worry about all this. And then, more relevant to today, the sacral part of the lumbosacral plexus, because this is the part giving rise. I mean, really, sciatic nerve is L4 to S3, so it's got a little bit of lumbar, but really, the sacral plexus is what's giving rise to a lot of the stuff we're looking at. I should say, another nerve we need to see this week is the nerve that's going through the ischial fossa, the pudendal nerve. For that, we're going to look for sciatic. We're going to look for the gluteal vessels. There might be a cadaver where we got posterior femoral cutaneous. That's a nerve providing sensation to the back of the thigh. We might have a cadaver with it. I don't remember. Okay. If you're presenting on this is a great mnemonic to learn the roots. Maybe you could learn that with just numbers. Whatever, you can find it. And if you don't, I'll do it discussion lab, okay? We can learn that mnemonic during lab Wednesday if the presenters don't do it. So anyways, these guys have to get out of the pelvis to go to these muscles, whether it's glute max or glute medius or glute minimus or tensor fasciae lata or whatever it is, or the pico-glute muscle. So the question is, how do they get out of the pelvis? They're going to do it mostly through the sciatic foramina, which are only formed when we add those really important ligaments that I talked about at the beginning of the lecture. And I'd say by 2 weeks from now, this picture here isn't going to look just like spaghetti, but it will start making sense to you, right? Like the femoral nerve, the trajectory. Here's the obturator coming through the obturator foramen. This will make sense to you, right? Here's lateral femoral cutaneous going right over iliac muscle, under inguinal ligament. Here's femoral nerve going under inguinal ligament, going to all the muscles in the anterior compartment of the thigh. Whatever. That'll start to coalesce. I'm kind of going quickly over this. I told you this is an intro to lumbosacral plexus. Okay. And you're gonna know these roots eventually, and you have to know them as PT people. And Raphael's gonna expect you to know them. So like gradually we'll start learning these. Okay. I just taught you obturator femoral and L2 to L4. I don't teach you a nice little mnemonic for the sacral plexus unless the presenters do it. The good mnemonic for pudendal, S2 to S4 keeps your stuff off the floor. All the goodies. I'll leave it at that. Okay. A lot of nerves to the short lateral rotators. Let's come back to that. Okay, let's come back to that. Okay, so I take a ligament from the spinous process, ischial spinous process, and a ligament from the ischiotuberosity, and run those to the sacrum. I just made greater and lesser sciatic foramina. Greater and lesser. And that's one of the main places a lot of the stuff's getting in and out of the pelvis. And then I can run stuff in and out of the pelvis through the obturator foramen. Okay. So, what's going through the greater and lesser sciatic foramen? Piriformis. superior gluteal vessels. Remember, we're going to find this because they're coming out above piriformis. Inferior gluteal vessels coming out below it. Sciatic nerve. Posterior femoral cutaneous nerve of thigh. And then lastly, pudendal nerve. I'll do it in blue. And vessels. Internal pudendal vessels. Good. So pudendal nerve is actually coming out of greater sciatic foramen. Then look what it's doing. It's going under the sacrotuberous ligament. And it's going into the ischioanal fossa. Anyone know why pudendal nerve is called pudendal nerve? Anyone know the root of that term? It's from the Latin, so it has ancient roots. This means shame, because this is the nerve going to your genitalia. So I don't know, theoretically, supposedly we're supposed to feel shameful about our genitals. I don't know, do what you want. I don't feel shameful about any part of the human body, but if you guys want to feel shame about that, that's cool, that's it. All right? But that's what the name is, pudendal nerve. Personally, I refuse to feel shame about anything in my body. So, pudendal nerve pops out of the greater sciatic foramen, goes under the sacrotuberous ligament, enters the ischioanal fossa. And what is it going to do? It's going to do three things. It's going to go to the skin of the penis and clitoris for sensation, hence the name, pudendal nerve, the shameful nerve. It's going to go to the external anal sphincter. We have, this is a somatic nerve. We have voluntary control over it. So we can, hopefully we've all done this. We can learn how to control that sphincter so we can defecate when we want. Yay, team. I really want to tell you a story. Chelsea, should I?
Yeah.
I don't know if I should. I don't know if I told this story. I used to in class. Should I tell it?
Yes.
Some people are shaking their head like I should. I think I should. The other branch goes to the perineum, like the skin between the genitalia and the anus. All right, I gotta tell you the story. I'm in the it's okay. You already think I'm a clown, so it's okay. This will just add more evidence. No, I only got 10 minutes.
You hyped it up so much.
Yeah. I'm in the Van Gogh Museum as a kid with my parents. And I'm so excited by Van Gogh. It's like, I forget that I gotta go to the bathroom, and it dawns on me, oh God, I gotta go to the bathroom. So I run around the museum to find the bathroom, and I get there, and they're like, yeah, that'll be $1 or whatever, and I'm a little kid, I don't have any money. I'm begging them to let me in. It's like Nazi, they did not let me in. Moral of the story is that I pooped in my pants. This was last year. This is when I was a kid. I still remember going back to the hotel, my older sister was looking at me like, around the tram, like, are we having fun, Alan? And, okay, but 5 years ago, I went back. It's the new Van Gogh Museum, but it's still the Van Gogh Museum. You know, the first thing I did is I didn't go to check out the art. I went right to the bathroom, and I took such a glorious dump. I triumphed. I redeemed myself. Yeah. Suckers. But yeah, they, back in the day, they were kind of Nazis. If you're a little kid with no money, man, doesn't matter how much you gotta go to the bathroom. But I pooped in my pants because, like, even if we have voluntary control over the external anal sphincter, at some point, right, the pressure builds up. But I digress. I shouldn't have told you this. Okay, so moving on. There we go. How do we find the greater sciatic foramen in the cadaver? Just look for the piriformis come down. Okay. And look for superior gluteal vessels coming out the top, inferior gluteal vessels coming out the bottom, sciatic nerve popping down there, etc. Okay, not too bad. All right, cool. So here's that nerve, pudendal nerve, and 3 branches, and we're actually only seeing one of the branches. But I don't care, and I'm not going to remove points if the branch that you see that we've dissected out in the ischial fossa you call the pudendal nerve. Technically speaking, what you're looking at is the inferior rectal nerve. That's the branch going to the external anal sphincter. It's really tricky to dissect out the nerve to the head of the penis and clitoris. I've actually never seen it done. Okay, it's really hard to do. I've seen it done once in the Caribbean when I was teaching down there, and the perineal branch is actually pretty tricky to do too. So you're really in our cadavers in the ischial fossa. You're looking at this one branch. Okay, all right. So it's a cool trajectory. S2 to S4 roots comes out of the greater sciatic frame. It goes under that sacrotuberous ligament. Now it's in that fat-filled space. Why do we have fat around the anus? Because we want it to be able to expand the feces to make its way through easier. Okay, right. Pudendal nerve, cool nerve. All right. By the way, a few little. Nah. Too many tangents. Okay. What about the lesser sciatic foramen? First of all, it's really hard to visualize where that lesser sciatic foramen is on these two-dimensional pictures. It's going to be way easier to get a sense for it on a cadaver. Because here's what you do. This is the sacrotuberous ligament. This will be easy to find. How do we find it? We follow the hamstrings up to the ischial tuberosity, which is what you're sitting on. Okay, easy to do. Find that ligament. By the way, this is one of the strongest ligaments in the body. Some of the bodies, we've sliced it in half. You can look at both ends, and it's like a millimeter thick. It's really tough ligament, you know what I mean? And you can put a probe under it. So if you, let me do that in black. If you put a probe under sacrotuberous ligament like this, we're gonna go under sacrotuberous ligament. Your probe is going through the lesser sciatic foramen into the ischial fossa. Okay. So what's going through there? Obviously, pudendal nerve, which I just talked about, and its vessels, which are the internal pudendal vessels. I'm being careful because it turns out there are blood vessels in male and female that come off femoral vessels, and they go like to the scrotum and labia majora in females. Those are external pudendal vessels. Okay. So, and by the way, there is no pudendal nerve in the front. Okay, so we only have one pudendal nerve, but we have a different kind of pudendal vessels. So the dudes following the pudendal nerve are the internal pudendal vessels, okay? And they're going into that fat-filled space. But there's a few other things. Remember that PQ muscle that makes a 90-degree angle? Obturator internus is going through there. Really, it's tendon, but whatever. That's going through there. Okay. And the nerve to obturator internus. Okay. So there you have it. Obturator nerve and blood vessels are going through the obturator foramina. And folks who are presenting in 2 weeks on 5. Okay. If you, again, please, and I'll help you. I'll show you. But if you find a cadaver where we got this posterior abdominal wall view, where we remove the GI tract, look for the obturator nerve and follow it to where it pierces the obturator foramina, and then follow it into the thigh. And so here it is, piercing the just about to go through the obturator frame. Okay. All right. Oh Lordy. There you go. We talked about this already. Are we cool? Okay. Remember how you find the gluteal vessels? Find piriformis. If there's stuff popping out above, it's the superior. If it's popping out below, it's the inferior. Easy peasy. Okay. So here's obturator. Here's a beautiful view of triceps. You can see the 3 parts, and the middle part's making that 90-degree angle under sacrotuberous ligament into the ischial fossa. That's kind of cool to see. Okay. Right. And these are the nerves to the PGOQ muscles. I'm going to blow over this right now, and we'll do this discussion lab. We're going to model this and think about it there. Okay. All right. I'm not going to ask you to find these, so don't worry about it. All right. Here it is again. Not asking you to find these. With the one exception, we will all have to find obturator nerve. These other guys are really small. They're difficult to find. Not that important. Okay. I think we have a cadaver, maybe even two, where the individual likely had piriformis syndrome. So it turns out sciatic nerve is actually two different nerves that are just traveling together for part of their life until we get to the popliteal fossa, right, the space behind the knee. Then what happens is the two parts of the sciatic nerve right behind the knee diverge. So common fibular heads laterally, and tibial just continues down into the leg and into the foot. So the sciatic nerve is really a combo nerve. However, in some people, this bifurcation, which normally happens behind the knee in the popliteal fossa, in some people it happens really high up. So it's called a high bifurcating sciatic nerve. And in some people, if you have a high bifurcating sciatic nerve, in particular, the common fibular branch will often just pierce right through piriformis. Remember, most people, if this is piriformis, sciatic nerve pops out below it, right? But in some people, common fib goes right through it, and then it is likely to be subjected to an impingement syndrome, right? Which makes sense. So you can see examples of that here. Sometimes both parts of sciatic they wrap around it, but that's the typical example. Okay. But we do have some. You at least have one cadaver with a high bifurcation sciatic, and oh, we're not too bad. Cool. Just a little tie-in. Piriformis syndrome can be difficult to differentiate from sciatica. And the reason is, in both cases, parts of the sciatic nerve are involved. In this case, parts of the sciatic nerve are getting compressed by a muscle. In the case of sciatica, typically that's due to a herniated disc. But in both cases, altered sensations running down the back of the leg, which is the distribution of the sciatic nerve, right? All right, so it can be difficult clinically to differentiate these. Okay, here's our superior and inferior gluteal vessels. We will have to find these, and we will be able to do that. Yay. I'm just going to look from on either side of piriformis, okay? You got to reflect, though, glute max and glute medius if you want to see the superior gluteal vessels. You can see they did that. That's medius, that's maximus. They had to reflect it to see it, okay? We've done that in some of our cadavers, right? We have a mnemonic for you. Presenters, learn it if you know what I'm talking about before Wednesday for these roots. It's a cool little visual numerical mnemonic. It's kind of cool. So we're going to look for superior gluteal nerve, inferior gluteal nerve, sciatic nerve, pudendal nerve in particular on Wednesday. I don't think we have this. If we do, it's only on one half of one cadaver. This is a nerve popping out. This is piriformis. This is sciatic nerve. Right next to sciatic nerve, innervating skin on the back of the thigh, okay? Posterior cutaneous nerve of the thigh. And you might see it on one cadaver, okay? So, just a heads up, sorry, I think we're gonna get out of here at 3:35, so only 5 minutes over, which is pretty good for me. But some of you might have just won some money, because I am going over. But, so just giving you a heads up about Raphael's exams. He's going to ask you to tell me about sciatic nerve. What are its roots? Where does it start? How does it get out of the pelvis? Greater sciatic foramen. Okay. What muscle is it next to? Piriformis. Okay. Now we're going into the thigh. What's its relationship to biceps femoris? It's posterior to it. Cool. Where does it typically bifurcate? Popliteal fossa. Tell me about it. You know what I mean? So just be prepared for that. And he's like really minute level. Oh, we know. So we're going to fall. So for everything we're kind of getting into today, especially the nerves, a lot of these guys we're gonna keep following for the next few weeks. Sciatica in particular, okay? Oh. This is just something to start thinking about, okay? I don't want you to worry about this too much. If you think about a spinal cord, and we all appreciate how there are segmental left and right spinal nerves coming off of it, cool. If you think about all of the somatosensory information coming into one spinal nerve, here's a mechanoreceptor, here's a pain receptor, here's a thermoreceptor, here's a proprioceptor, got it? All of the somatosensory information coming into one spinal nerve, that will map out a dermatome. And you could make these funny pictures of the body, which most of you have seen before, these dermatome pictures, okay? And of course, these are clinically significant. Let me just give you an example of kind of a neurological one. There's a really interesting neurological condition where in the cervical, like, spinal cord, remember, God, there's a central canal. So in some people, the central canal cavitates out, starts to enlarge, and it starts to impact pain and temperature fibers that cross, which you'll learn about when you take a neuro course. They cross right here, in the spinal cord. So if that central canal cavitates, gets larger, that's the first tract that's impacted. So you lose pain and temperature. It's in the cervical region for reasons you don't understand yet since you haven't taken neuro. But anyways, those fibers crossing right here are just coming from the upper limb. So this syndrome, sometimes the first example, someone knows something's going wrong. They're taking a hot shower, it's the winter, they feel the hot water on their head, they feel it on their feet, and it's like, I don't feel anything on my shoulders. That's a little bit weird. They start to get concerned, and they see a neurologist, and it turns out they have this cape-like loss of pain and temperature. Syringomyelia is the condition. But anyways, it's a dermatomal presentation, C3, C4, loss. That's where dermatomes can come into play. So you're going to see patients too with like particular dermatomal loss, things, okay? And then you could also like relate those dermatomes to the spinal nerves that are, right, innervating the skin in that dermatome. That's what this picture is about. And a lot of this we're just going to pick up as we make our way down the lower lid. Okay? The only one I think that's really relevant to us is posterior femoral cutaneous in this region. We haven't really talked about other cutaneous nerves. Okay. To end, there are little cutaneous nerves that go over the skin of the buttocks. These are called cluneal nerves, and you don't have to find these on the cadaver. Okay, so they're cluneal nerves. See, there's a number of them. Some come from above. Some come from below. Some come from above. Some come from below. Really difficult to keep on a cadaver if you remove the skin. So you're not going to see it. All right. Sensory to skin over the buttocks. I think we're done. That was a lot, wasn't it? We got through 91 slides. You hate me.